Endoscopy guidance has enhanced our understanding of the anatomy, physiology, and pathology of lacrimal disorders. The development of endoscopic techniques has contributed to the development of minimally invasive lacrimal procedures, and congenital nasolacrimal duct obstruction is not an exception. So let us go through the procedure of irrigation and probing under endoscopic guidance. The instrumentation needed apart from endoscopy system is mainly a 1 ml syringe, 23 gauge cannula, short taper nettleship punctum dilator, Bowman's lacrimal probe, periosteal elevator, and suction cannula along with the apparatus. The procedure is performed under short general anesthesia with a laryngeal mask airway. Nasal mucosa is decongested with cotton buds soaked with 0.025% oxymetazoline. The upper eyelid on the unaffected side is raised at the junction of the medial and the middle third from the margin such that the area of the punctum and the horizontal canaliculus is visible and is taut. The upper punctum is dilated using the short taper nettleship punctum dilator. The dilator is inserted perpendicular to the punctal opening and then is turned to align parallel to the lid margin to enter the horizontal canaliculus. This procedure is then repeated on the affected side. Irrigation is performed using a 1 ml syringe and a 23 gauge straight cannula to confirm the nasolacrimal duct obstruction. Bowman's lacrimal probe using age-appropriate size is then used in a similar way. First, it is inserted perpendicular to the punctum, then turned horizontal such that it is parallel to the lid margin and advanced till hard stop is felt. The probe is then turned perpendicular and advanced in a downward, lateral and posterior direction. The probe is brought to a halt the moment any obstruction is felt. The cotton buds are removed from the nasal cavity. A 2.7 mm 0-degree endoscope is used to visualize the nasal cavity. The inferior turbinate is medialized using the blunt edge of the periosteal elevator, and a direct view of the inferior meatus is obtained. Probe is then advanced and the obstruction is overcome under direct visualization. The probe visualized in the meatus is then lifted with the help of the elevator to widen the opening. Irrigation is done to confirm the free passage of distilled water. A retrospective interventional study at our center analyzed the profile and outcomes of congenital nasolacrimal duct obstruction which had undergone probing elsewhere without endoscopy guidance and were referred to us for a second or a third procedure. 100 eyes of 82 children had experienced failed probing without endoscopic guidance done elsewhere, of which 63 cases underwent intervention, this time under endoscopic guidance. Of interest were 35 cases of simple congenital nasolacrimal duct obstruction which had a simple membranous obstruction at the nasolacrimal duct opening. Post-intervention, 32 of these cases had a successful outcome with probing under endoscopy guidance, and the remaining 3 had developed atonic sac and were successfully managed by dacrocystorhinostomy procedure. Of the 28 cases of complex congenital nasolacrimal duct obstruction, 12 cases had bony obstruction and severe atonic sac requiring dacrocystorhinostomy surgery. The remaining cases were treated with probing with or without Monoka-Crawford stent or balloon dacroplasty under direct visualization using endoscopy with good outcomes. So to conclude, endoscopy guidance helps identify a variety of congenital nasolacrimal duct obstruction subtypes and facilitates the performance of additional procedures along with probing in a single sitting to achieve optimum outcomes. Thank you.